I would very much like to welcome you tonight to this webinar on what to teach your registrar about prenatal screening, with a particular focus on genetics and reproductive carrier screening. My name's Simon Morgan. I'm a GP, a medical educator here in Newcastle, and some of you may have met me, at least online, through other webinars that GPSA have delivered. And as I say, it's great to have you on board, so thanks for coming along. And as is custom, we would like to start the meeting with an acknowledgement of country. So GPSA acknowledges the traditional owners of the land in which this meeting is taking place and pay respects to their elders past, present and future. And I'm joining you tonight from the lands of the Awabakal people, just south of the Hunter River here in Newcastle. And lots of different countries we're being joined from, no doubt. Our talk tonight, genetics and reproductive carrier screening, and it's a great pleasure to introduce two speakers from Sydney. Firstly, Dr. Caitlin Forward, who's an advanced trainee in clinical genetics, currently working as a fellow at the Sydney Children's Hospital. Caitlin, I think most importantly, is an RSCGP fellow, and in fact, most excitingly, she was one of our registrars at the old Valley to Coast training program, and she was my registrar. So it's a great thrill to have her on tonight, not only talking about genetics, but genetics from a general practice perspective, even though that's a little bit in the past for her. She's also an adjunct assistant professor at Bond University, where she's worked teaching medical students and writing curricula. And joining her tonight is Kirsten Boggs, who provides a really important perspective as a genetic counsellor who's been working with the Australian Genomics Health Alliance since 2016, specialising in paediatric rare disease and genomics. She has a special interest in the consent process for genomic testing and works across two main children's hospitals in Sydney at Randwick and Westmead. So it is a great pleasure to introduce you both.
Thank you very much. So I'd also like to just thank Kirsten for joining us tonight. She's an integral part of our genetics team and will explain the role of a genetic counsellor, but also is truly an expert on all things carrier screening, as well as many other aspects of genetics and genomic testing. And also to thank GPSA for having us, and to Simon for inviting us, and also for teaching me so much in that early general practice training. And I still very much identify as a GP and will always identify as a GP and have a huge amount of respect for the work that GPs do. So the outline of the talk is fairly broad objectives. We won't be able to allocate sufficient time to cover the first one, but we'll try to discuss in some detail the emerging aspects of genomics as they relate to general practice. And then really the focus is on how you will be able to teach your registrars about reproductive carrier screening and introducing some resources and analogies that we find helpful. And then also talking about Mackenzie's mission, how it works, how you can get involved, and hopefully having some time for any questions that come up. So genetic or genomic testing, so the two terms are often used interchangeably, and essentially genetics is the study of hereditary, or the role of genes and their role in inheritance. And then when we talk about genomics, we're usually referring to the larger scale studies, and so that may be undertaken in order to find a single variant or two variants in the case of autosomal recessive conditions. And in our local laboratory, our lab is divided into cytogenetics, which looks at arrays, karyotypes, FISH studies, and then the genomics lab looks more at panel testing, trio exome, and moving towards trio genome or singleton exome and genome tests as well. So what is genetic counselling? And I've used this slide that Kirsten's presented, and I've highlighted some things in different colours because genetic counselling, I think, also has some features which overlap significantly with general practice, and that includes a communication process which aims to help individuals, couples and families understand and adapt to the medical, psychological, familial and reproductive implications of the genetic contributions to specific health conditions, and that really does have relevance to the general practice setting as well. So across the lifespan, GPs are potentially doing genetic testing or considering genetic testing, and that's everything from the preconception, reproductive carrier screening domain to the testing during pregnancy, talking about Down syndrome, trisomy 13 and 18, Edwards and Patau syndrome, and then newly emerged non-invasive prenatal screening, combined first trimester screen, and also during pregnancy, reproductive carrier screening. There's newborn screening results that no doubt come in, and disorders that are diagnosed through that program. And then throughout childhood, adult onset familial diseases. And then referring back to the Red Book, there's many sections that are very useful on cystic fibrosis, Down syndrome, Fragile X, amongst all the other conditions that GPs are well placed to talk to patients and families about. Which patients are at risk of a genetic condition? So how do you identify this? So one way that it might come up in a general practice setting is you suspect a genetic diagnosis by recognising signs and or symptoms that suggest a genetic condition. And an example of that might be that you're examining a child and you notice that they have multiple large cafe au lait macules and you suspect a disorder such as neurofibromatosis type 1. It may be that in the interpretation of a family history, there's information that comes out, and also from the results of screening programs or investigations that you've undertaken or your registrars have undertaken. I've included here the family health history screening questionnaire and included in the Red Book sections, and this is really in an ideal situation, and we understand how time pressures can impact on the ability to do a comprehensive family history that should include first and second degree relatives on both sides of the family and ethnic background, as well as considering the age of onset of disease and age of death. And I know an example in the Red Book was that this questionnaire perhaps could be given to people in the waiting room to fill out and should be updated every three years. The following should or could prompt consideration of genetic conditions, and that is if intellectual disability is identified, either in a child or an adult, there are multiple pregnancy losses, stillbirths or early death, children with congenital anomalies, or in particular ethnic backgrounds. And consanguinity is always something that alerts us to further consideration of genetic condition. And there's lots of different ways to ask that. An example could be, is there any chance that a relative of yours might be related to someone in your partner's family? Or I might say, is there any chance that you and your partner are related? And just express that that's a routine question that we ask everyone. And then if that identifies areas of concern, then you can provide the opportunity for carrier screening or referral for genetic counselling based on those risk factors. But really, as Kirsten will go into, any couple has a risk of having a child with a genetic condition despite the family history. So a lot of the rest of the talk is truly relevant for anyone who's planning a pregnancy. So a question was raised in the pre-talk about ethical considerations in the pre-questions. And so part of the ethical considerations for an autonomous choice to be made really include considerations around autonomy and making the choice or the decision to undertake testing freely and without coercion. It should be reflective of the individual's own values and be an informed decision. And genetic testing also raises considerations around privacy. Who in the family, if anyone, do they want the results to be distributed to? What impacts does it have for other family members who may or may not have a right to know? And also, of course, the genetic discussions are really based around relationships as they're presented. And it may be that, in fact, there's issues around paternity and relationships within the family, and also that can bring up consanguinity as well. And also to be aware that even if we undertake genetic testing, we can't exclude completely that there's not a genetic disorder that we can't test for, and also that a negative result does not exclude. There can be false negatives, so the test doesn't pick up every change. It's really only the best that it can be at this where the technology's evolved to. So there's quite a few considerations there, and we can expand on those. So just to break it up with the Zoom poll, thinking about the genetic testing or genomic tests that have already been requested in your practice. We wondered if we could get a little bit of a poll as to who might have requested chromosome microarray, non-invasive prenatal screening, hemochromatosis gene testing, and reproductive carrier screening. And that part of that also including whole exome or genome sequencing. And keeping in mind that there is a Medicare item number for chromosome microarray in certain situations, so that maybe some tests that you have previously ordered. Wait to see some responses.
So there's a question just actually with a bit of clarity around what a couple of those things mean. Things like chromosome and microarray, and indeed reproductive carrier screening may not be clear, but I guess we're certainly touching on a couple of those things and talking in detail about reproductive carrier screening.
Absolutely. So certainly in the pregnancy setting, it seems that, you know, with 97% of respondents having requested non-invasive prenatal screening, and this is just to highlight that you're all already having discussions with parents-to-be and pregnant couples about genetics, and all of these really involve discussions. And as I'm sure I reflect in my own general practice, as you've done things, you know, once, twice, and you become more comfortable with it, then it becomes a lot easier. Chromosome microarray, often the difficulties may be in the interpretation of the results. And certainly, I know as a GP I thought about it, but I didn't actually ever request a chromosome microarray. And for the 4% of people who have done that, hopefully that's something that you feel comfortable to do. And
are you happy very briefly just saying what that is, Caitlin? I know we're not spending much time on that.
Yeah, so we will come to that as well.
Okay.
So chromosome microarray, there's different ways. There's a CGH array or there's a SNP array, and basically it's looking for copy number variation in chromosomal materials. And you might talk about that with the analogies. The person's going to use a brilliant analogy, and we might link that back into how we can discuss chromosome abnormalities or copy number variants. And then whole exome or genome sequencing. So there is a new Medicare item number for paediatricians to order whole exome sequencing for paediatric patients with a number of conditions, including moderate intellectual disability or multiple congenital anomalies with dysmorphic features, in conjunction with a geneticist. So that is a relatively new option that's come out. So just then identifying some resources. I loved several resources when I was working as a GP, and in fact it helped influence my decision to come into genetics, particularly the family cancer resource that was available for discussing familial cancer predisposition. But the Australian Genomics Health Alliance, the New South Wales Centre for Genetics Education, and then there's some consumer ones that you may have found, but from the RACGP, the Red Books, great, and then the Genomics in General Practice book that Simon Morgan was heavily involved in the generation of is a truly exceptional resource and really covers so many fantastic areas, both diseases and concepts, and it would have been something that I would have really directed registrars to as a wonderful resource. But where the rare, I still need to maintain my CPD. So I did this as a CPD hour-long module, and Martin Delatecchi from VCGS talks through the module, and it's also an excellent resource. They've got some more extensive and brief fact sheets in their clinical resource section, as well as patient resources and frequently asked questions. So if you haven't seen that, or you would like to direct your registrars to a good starting point, that one's truly excellent. The New South Wales Health Centre for Genetics Education is also a brilliant resource, with education available for GPs and lots of screening and fact sheets. So that is also a resource that even we use regularly and refer patients to often. The Australian Genomics Health Alliance, just to flag that this is a large part of Kirsten's work, both with Mackenzie's mission and then also the acute care flagship. So we can, in certain situations, get either an exome or a genome result for a patient in as fast as 3 days, is probably the fastest in certain critical care type situations. So we're really moving towards a rapid genomics era, and also through them, hopefully a national consent form will be generated. So now to another Zoom poll. So just a true or false. A couple who receive a low chance screening result still have a chance of having a baby with a genetic condition. True or false. Number 2, a couple who receive a high chance screening result will be unable to have children together in the future. True or false. And then reproductive carrier screening can also screen for chromosomal conditions such as Down syndrome or trisomy 21. True or false?
Just by way of context, we did actually, so we asked, as often the case in these webinars, Caitlin's given a very broad overview of where, I guess, general practice and general practice training and registrar training and interfaces with genetics and genomics. And it's a huge, huge area. So she's really hopefully just touched on that. And we're going to channel in now to much more specifically around reproductive carrier screening. So just before we do that, Caitlin, I'm just really conscious that many supervisors will probably be thinking, oh, well, that only just confirmed my uncertainty and ignorance around, this whole emerging field about genetics. What do I do when a registrar asks me a question? I don't, it's a real challenge to know how to address a question on genetics. What would be your advice be where this area is, evolving and I think our supervisors are still really coming to grips with the this emerging part of our practice?
Yeah, so I guess a lot of us have probably done teach the teacher type training sessions. So I think really, I guess, exploring their understanding of genetics and then seeing, where would they go, what would they do, and then reinforcing the principles that are there and that are solid, and using the opportunity to teach those areas that might need a little bit more input, and then using the resources I think are really helpful as well. And we will describe some analogies that we use, and everyone is different. And so I think knowing that there's such a wealth of information out there, and everyone will find a resource or a way of doing things that they prefer. And I think just recognising that there's many different ways to do it, many resources available, and it's really finding a way that feels comfortable for you. But I think initially just exploring their understanding of genetics, chromosomes, genes, inheritance patterns, and then and going from there.
Great. All right, I'll leave you to it. Thanks, Kirsten.
No worries. So I thought I'd just start off by, I guess, introducing the topic of reproductive carrier screening and how it can be incredibly important to families. So the reason that our study is called Mackenzie's Mission is that it's named after baby Mackenzie. So she was born in 2017. And that's a picture of her there with her parents, Rachel and Johnny Casella. So she was actually diagnosed at 10 weeks with a condition known as spinal muscular atrophy, or SMA. And this condition, for those of you who don't know the condition, it's a muscle condition, and children are very severely affected, and often with this type that she had, they die quite early on in childhood. So very sadly, Mackenzie passed away at 7 months of age from SMA. Her parents, Rachel and Johnny, actually asked why they hadn't known that they were at increased chance of having a child with a genetic condition. Particularly for them, they had thought that they'd done all the testing that was available to them, both pre and during the pregnancy. So this came as a huge shock to them. So they actually lobbied the government, incredible people, and they lobbied hard. And basically, as of the 1st of March 2018, Mackenzie's Mission was born, and we basically got funding to look at implementing reproductive carrier screening across the country and how we could do that within Australia. And so Health Minister Greg Hunt said that he would like to see preconception testing become routine and free for everybody thinking about starting a family. So I guess in terms of genetic testing, there's so much available. Genetic testing pre-pregnancy and in pregnancy. So this is just a graphic from that Centre for Genetics Education website. They have a booklet that talks about different types of prenatal testing that's available. So you can see here, you've got potentially using genetic screening on embryos, and then you've got the start of a pregnancy, either through IVF or naturally. You've got all of your ultrasound screening tests sort of start from about 10 weeks of pregnancy. So that's with your NIPT and so on. I've just put this little highlight in here to say that basically reproductive carrier screening is ideally done before a pregnancy, but we know that 50% of pregnancies are unplanned, so can actually be done early in a pregnancy, but I guess the earlier the better, so that couples have options available to them if they do come back as having an increased chance of having a child with a genetic condition.
And also an advantage of doing it earlier is that we all know as a GP that once a pregnant couple comes in, you've got diet, schedule of tests, model of care, all those other things to discuss. So if you can do this one pre-conception, it's one less thing to do.
Yeah, and just gives people time to think about what they would do with those results as well. And the options do differ, which I'll go through in a minute too. So as we were saying before, so many tests. Basically, this is just a couple of examples. So talking about the chromosome microarray or people talk about an array, a microarray, CGH array, they're all the same. This tests the baby's chromosomes either via doing a CVS or an amniocentesis, and it looks for duplications or deletions. So an example of that is a condition known as velocardiofacial syndrome. So that's also 22q11 deletion syndrome. So that's when there's a bit missing from the Q arm of the 22nd chromosome and can cause that particular condition for a baby. As you know, you've got the NIPS or NIPT test that tests the mother's blood for the most common fetal chromosome abnormalities. So things like Down syndrome. And then you've got reproductive carrier screening. So it actually tests parental DNA for genetic variants, and usually it will test a subset of severe childhood onset conditions. So the example there is spinal muscular atrophy. So when I talk to families about genetic testing, I use lots and lots of different analogies, and as Caitlin said, it will depend on what feels right for you, what feels right for your registrars, and kind of what gels with the family. So sometimes they won't particularly get a particular analogy, so you might have to change what you're saying. So I use things like talking about a library. Some people use the analogy of sort of cake recipes, making a cake, Google Maps, sort of looking at a broad spectrum, so big Google Maps zooming right into Street View, that sort of thing. So I'm going to give you the library analogy.
And I've seen all those analogies used and they all work. So, as Kirsten said, it's just thinking about the New South Wales Centre for Genetics Education has a different analogy to this, but this is certainly the one that I tend to use as well.
Yeah. So what I say is imagine that your DNA sort of chromosomes are like a library, and in the library you've got your chromosomes, which are the shelves, bookshelves, and there should be 23 pairs of bookshelves. A microarray will just go in and check that the right number of shelves are there, so they'll see if there's bits missing or bits repeated. For a detailed genetic test, so when we're talking about going in and actually looking at the specific spelling of the genes, so we take a book off the shelf, that's one gene, check the spelling, put it back, take another one off, check the spelling, put it back. So that is the analogy that I use, in that the chromosomes are like the shelves and then the genes are like the books on the shelf. So when we're talking about reproductive carrier screening, we're actually talking about taking parental books off a shelf and reading through those genes to see if we can find spelling changes that might mean that they're at increased chance of having a child with a genetic condition. So what is reproductive carrier screening? It provides prospective parents with information about their chance of having a child with an inherited genetic condition. So while all of these conditions are individually quite rare, collectively they do actually occur relatively frequently. And so we'd say we're expecting that about 1 to 2% of couples will actually have an increased chance of having a child with one of these severe childhood onset genetic conditions. Previous research has shown that there is interest in and support for carrier screening, provided that it's optional. and that screening is actually relevant to all prospective parents regardless of family history. So there are limitations when thinking about things like family history and ethnicity, and obviously thinking about Caitlin's slides previously, all of that can be really, really important to, I guess, give information about whether there is a particular condition in the family. But a lot of the time, most children born with a genetic condition actually have no family history. If we think about Mackenzie's story, she was the first person in that family to be born with that particular condition. And that's because carriers are healthy. So people don't know that they're carriers. And the way that things used to work in genetics is, you know, a child would be diagnosed with a particular condition, either recessive or X-linked. We'd then sort of go back and test the parents. Yep, okay, found out that they're carriers. We then do what's called cascade testing, where we test other members of the family to see if they're carriers. But basically, you know, that approach actually relies on the birth and diagnosis of an affected child, which is incredibly traumatic for that family to go through. Also thinking about limitations of ethnicity, you know, our society is increasingly multicultural, so it can be difficult to just focus on one particular ethnicity. So I'm sure you've seen this, but just a reminder that the RAINS-COG guidelines from last year are basically saying now that information should be made available on reproductive genetic carrier screening to all women planning a pregnancy or in the first trimester of pregnancy. So they go on to talk about different options for carrier screening. So you can, I guess, test for a limited selection of the more frequent conditions, or you can screen through an expanded panel that contains many, many different disorders.
Can I just make the point there, Kirsten, that in fact the RACGP have adopted that recommendation through the genetics resource that Caitlin referred to, and so really it's incumbent on GPs also to apply that recommendation in their practice, which is why I'm so pleased we're having this webinar tonight, because really it is best practice now to be routinely offering reproductive carrier screening information to either preconception or early pregnancy patients.
Yeah. And also just to flag that screening also includes hemoglobinopathy screening still, as it always has.
Yeah. So just a reminder about the inheritance patterns that we are screening for when we're talking about reproductive carrier screening. So we're talking about autosomal recessive conditions. So that's when both parents are carriers of a particular condition. So they've got a mutation or variant in one copy of the gene, but their other gene is working normally, which is why they're healthy and well. But together they have a 1 in 4 chance of having an affected child. That's where both parents pass on the copy of the gene that's not working. So SMA or cystic fibrosis are examples of a recessive condition. You've also got X-linked inheritance. So many reproductive carrier screening companies actually will test for these as well. So that's when the mother is a carrier for a particular condition on her X chromosome. So you can see here that the male only has 1 copy of his X and 1 Y. Female's got 2 X's. She's got a change on 1 gene, but her backup copy is working, so she's healthy and well. But she does have a 1 in 4 chance of having a male baby that's also affected with that condition. So if he inherits the X that's got the faulty gene on it and has a boy, then that son will be affected. So what are the reproductive options available to people who do come back as having an increased chance of having a child with a genetic condition? So there are a number of different options, and certainly we see people making all different decisions and support them through any decision that they wish to make. One option is that they can go through the IVF process, and secondary to that can have something known as pre-implantation genetic testing. So that's testing of the embryos before they're implanted back to see whether that embryo is affected or not. So they would only implant embryos that are not affected with the condition and discard embryos that are affected. And certainly that has its pros and cons, and we would talk to people in a lot of detail about that. Otherwise, people can conceive naturally. And then they can have a prenatal test, either via CVS or amniocentesis, and basically determine whether the pregnancy is affected with that condition or not, and then make decisions based on that. So if it's positive, the couple may consider termination of pregnancy, or they may wish to continue the pregnancy and just use that information to plan and prepare. And certainly we'd support people either way. They also may choose to conceive naturally and choose not to test, but they may choose to test the baby at birth. Otherwise, some people can have used donor egg or sperm or embryo, or look through adoption, or they may choose not to have children. So lots and lots of different options that people will consider. So just wanted to talk very briefly on the history of reproductive carrier screening, particularly I guess thinking about the targeted community genetic carrier screening that's been happening in Australia for a long time. So particularly within the Ashkenazi Jewish community, because of the founder effect, that particular community is at higher risk of having children with the condition known as Tay-Sachs disease. And for those who don't know, that's quite a severe condition where kids, are sort of born normal and healthy, and then there is a build-up in the brain of, what is it?
Glucose.
And then basically that can cause very severe intellectual disability, seizures, and then eventually death. So in Sydney in the early 90s, and then in Melbourne, they started doing testing for Tay-Sachs disease through enzymatic analysis in the Ashkenazi Jewish population. And then once molecular testing was available, they moved to that and then added further conditions. So currently, community screening within the Ashkenazi Jewish population actually screens for 9 different conditions. So Tay-Sachs, cystic fibrosis, and a bunch of other different conditions. And everything but cystic fibrosis is actually targeted at Ashkenazi Jewish specific variants. So these are all conditions where there's a higher chance within that population that they will have a child with one of those conditions.
So gangliosidosis.
Yep. So then we moved into a high school program. So in 1997 in the Jewish high schools here in Sydney, we were offering carrier screening just for Tay-Sachs disease. It used to cost $40 per participant, and the testing was on blood. You can see there the uptake's about 33%. In 1999, they removed the cost barrier, and you can see there that jumped to 85%. And then basically once we moved to using a cheek brush and then adding on different conditions, the uptake was very high. So these kids are usually in about year 11, and they get an education session with a genetic counsellor, and then they have a follow-up appointment to have their mouth swab sample collected a couple of days later. So the lesson here is basically that the removal of barriers actually results in increased uptake for carrier screening. So internationally, there's similar programs in other countries. In Israel, I know that they've been doing large-scale targeted population screening for a long time, particularly for conditions like Fragile X and cystic fibrosis, and it's been government funded for a long time there. Also, just to very quickly mention that the Cyprus community has also had a long-standing carrier screening program for thalassemia as well, which resulted in far less children born with thalassemia in Cyprus, and that's been going since the late 70s, early 80s. So when talking about reproductive genetic carrier screening, there are many, many different options for testing. Basically, as it stands at the moment, outside of Mackenzie's mission, which I'll talk about in a moment, it is a user pays basis. So people do have to pay privately. and it can range from sort of the $385 for the VCGS testing, which tests for the 3 most common conditions, so cystic fibrosis, SMA and Fragile X. And you can see here that's $385 for blood or saliva. They get their results back in about 10 days. And they did a study on the first 12,000 people screened, and that the average age of people accessing that was about 34. And you can see there the split is 87% metro, 13% rural. So there's a list of other commercial companies that will, I guess, depending on the company, offer different types of screening. So you can get screening just looking at the 3 most common conditions within the particular population, up to expanded screening, and it ranges in price from $300 up to over $1,000, depending on which company you go for. So that is not an exhaustive list, but that's just some of them that are out there. So commercial companies will all report results of the individual. There's a number of different providers, so different providers have a different range of conditions covered and therefore costs. The higher the number of conditions screened for, the higher the cost. There's also, I guess, the more things that you screen for, the bigger chance that we'll find that that person is a carrier. It's patient pays, and so therefore there's inequities that are inevitable. So how do we move forward from here? So I'm going to talk about Mackenzie's mission and how it fits in the scope of reproductive carrier screening. So it's embedded in the Australian Genomics Health Futures mission, but it was initially a program of the Australian Genomics Health Alliance. The Genomics Health Futures mission basically is $500 million invested in genomic research over the next 10 years, and Mackenzie's mission is the first project of this. So we received $20 million to implement this, funded from the MRFF. We have a huge amount of people working on Mackenzie's mission, a number of different committees, operational team, program coordinators, and so on, that have been crucial to getting this up and running. The overall aim of Mackenzie's mission is really to understand how to offer reproductive genetic carrier screening as a national program. So really what we're trying to see is how many people actually want carrier screening out there. Of those that do, what decisions do they make if they do come back as increased chance? We have an ethics team investigating the ethics of reproductive carrier screening. We have psychosocial researchers that are following up with all the different couples and asking them about their views on reproductive carrier screening. We have an implementation science team as well, looking at how we can really prepare Australia's workforce for this. In the interest of time, I'm actually going to skip this video. This is just an introductory video about Mackenzie's mission, but you can watch it on our website, mackenziesmission.org.au, and maybe we can ask that the link be sent around later, if that's okay. So the current challenges as we see them really in terms of offering reproductive carrier screening to patients is that there's this obvious access inequity with the commercial providers in that, you know, people have to pay, and so automatically that creates a barrier for people accessing that. There's also a lack of awareness both publicly and professionally about reproductive carrier screening. And you can see from that research from VCGS that really the geographic location, so the majority of people that are accessing reproductive carrier screening are actually from major metropolitan areas. And so that's really creates an inequity as well. In terms of resource burden, so everyone is a carrier for something. So if you looked at any one of us, if you looked at my genes, I'd be a carrier for about 2 to 3 different severe childhood onset conditions. So the more that you test people individually, the more results you're going to get back that people are carriers. And then that creates resource burdens, not only for the laboratory, but for genetic counsellors dealing with those results, and GPs talking to patients about them, having to go on and then test the partner. You know, majority of people, the partner's actually not going to be a carrier for the same thing. So really, you know, increasing everyone's workload and anxiety maybe for nothing. The different companies really, I guess, they test for a varied number of different genetic conditions. Some test for conditions that are mild, that are variable, or that are adult onset, and this really complicates their decision making for the couples and can cause unnecessary anxiety. So Mackenzie's mission, in order to address some of these concerns, so firstly, the testing is actually free through the study, so couples do not have to pay for testing. They participate in online education and engagement. We also do education mostly online at the moment with particular GPs who want to come on board and recruit for us. We're also targeting recruitment across Australia. So each state will have different criteria that they need to fulfil. In New South Wales, particularly, we're focused on southwest and western Sydney and the Hunter New England region to get some regional recruitment. So not everyone will be able to recruit for the study. It'll be only from certain targeted areas. Also, to address the resource burden, we're actually issuing couple-based results. So people get screened as a couple at the same time, and we issue a result based on the couple. So most people will come back as a low chance result, and then those that are increased chance will be both members of the couple have been found to be carriers of a recessive condition, or the female's been found to be a carrier of an X-linked condition. In terms of addressing the clinical utility, so we actually had a sort of year-long gene selection process where we went through all the recessive and X-linked conditions that are out there that we know about, and decided whether we should be screening for them as part of a national program or not. And we do have ongoing review of those genes.
And there's a paper published about that, which we can share as well.
Yes, yeah, there is. So what are we actually screening for through Mackenzie's mission? Approximately 1,300 genes associated with over 750 different genetic conditions. It's a couple screening approach, and when we were choosing conditions to be screened for, basically it had to be a serious childhood genetic condition that had onset in childhood, significant impact on lifespan and or quality of life, or that it was a condition that results in frequent and or burdensome medical treatment. On the flip side of that, it might be something that could be completely treatable if detected early enough, and that not on newborn screening. Some of them are on newborn screening and some of them aren't, just depending on the condition. It does include the most common conditions, so cystic fibrosis, SMA and Fragile X we're screening for as well. And we're talking about recessive and X-linked conditions. Just importantly to note, non-syndromic hearing loss is actually not screened for as part of Mackenzie's mission. And we've sort of gone backwards and forwards on this, but decided for now that it doesn't quite fulfill our criteria, but that may change. We've got somebody doing a PhD specifically on whether we should include those genes as part of a screening program or not. Oh, there's the paper. So there are some testing limitations. So it is a screening test. Obviously, it does not report individual carrier status, so it's relevant only for the couple being tested. It doesn't test for mild or adult onset conditions. It won't screen for all variants associated with the genetic condition, and will not screen for chromosomal conditions.
So that was one of the true-false questions from earlier. Yeah.
So patients should still be offered things like NIPT or combined first trimester screening. Importantly, thalassemia screening should still be offered, particularly through Mackenzie's mission. We're only able to detect beta thalassemia and not alpha thalassemia due to a technical limitation with our labs. So just very important that everyone's still offered their routine thalassemia screening as you normally would. It cannot test for all genetic conditions, so things that are dominant within a family, those will not be detected as part of this, or de novo conditions. So they're conditions where there's a change in the child for the first time. That sort of condition will not be screened for. In rare situations, people may also find out information about their own health. So that's particularly true of X-linked conditions, where female carriers can sometimes have a milder form of the condition and sometimes not even know about it until they're detected as being a carrier. So that's just important for people to think about before they go ahead with screening.
And Kirsten, just on that, I think you make the point around Mackenzie's mission, but I think if we're talking just generally around reproductive carrier screening, even using a commercial system like Prepare with the 3 common genetic conditions screening for, to make that distinction that we're still offering the chromosomal testing as per usual. Because most participants on the webinar obviously will be engaging in that process up until hopefully Mackenzie's mission results become mainstreamed and people have broader access.
That's correct. Yeah. So yeah, those limitations are relevant to any kind of carrier screen that you do. Yeah.
Now, just to say, we've got about 10 minutes, so I know you're conscious of the time, so just to let you know. Yeah.
Yep, I'll just quickly go through the study process, basically just to say that we're looking to recruit about 10,000 couples across the country. Couples have to be recruited by selected healthcare providers, and as I said, we are targeting specific regions in each state, so it would depend on your state as to who can recruit and from where, but I will put up the contact details if that's something that you and your practice would be interested in. Couples actually enrol online through an online portal, and this is to, I guess, lessen that resource burden. So couples go home, they're given a study invitation sheet, they go home and enrol through the online portal, and this is just some of the stuff that they enter. The decision aid is optional, but we've found that that's actually really useful for people because it does get them to think about what they would do if they come back as increased chance, which is something that I think people don't really think about until they're kind of in that position. So it's always good for people to maybe have that conversation, particularly between themselves and their partner, about, you know, would they consider things like termination of pregnancy, or would they think about things like IVF and testing of the embryos? And people may not always be on the same page. And that's when genetic counsellors can step in and help facilitate those discussions. So couples enrol through the online study portal. They make a decision about whether or not to have reproductive carrier screening. So just because they enrol doesn't mean they have to say yes to screening. Couples who then choose to have screening consent to testing, all done online. Both members of the couple provide samples via post. So we actually send out a mouth swab kit, and then that they do their mouth swab and that gets sent back to the laboratory. And then couples are invited to complete research surveys and interviews should they wish. So our results, currently taking about 8 weeks in both New South Wales and Victoria and 4 weeks in WA. We've got higher restrictions with COVID, so it's been a bit harder to get things through the lab. Most couples will come back as low chance. They get their results through the online portal and a copy goes through to the referring doctor, and then they are advised that if they've got questions, they can follow up with the study genetic counsellors. Couples that come back as increased chance, so that's where they're up to 1 in 4 or 25% chance of having a child with a genetic condition. That's when the study genetic counsellors are heavily involved. So we actually return those results back to the couple, and we call the referring doctor and talk you through that as well. And then we arrange genetic counselling and appropriate referrals from there. So the healthcare professional involvement. If you'd like to be involved, you can send an email to the Mackenzie's mission team.
Which is Kirsten.
So that's the main team down in Victoria, and they will forward it on to the relevant state. So it's studyteam@mackenziesmission.org.au. We'll then get you to fill in an expression of interest form, and you'll need to participate in an education session, generally via Zoom. You then receive a welcome pack in the mail and you can start recruiting from there. So generally it's quite a quick process. The education session generally lasts for about 40 minutes, depending on whether people have got questions or not. So just, I guess, to clarify the key points. So we've got that reproductive carrier screening ideally is offered pre-pregnancy, but also can be done early in pregnancy. That it promotes reproductive autonomy, and that reproductive carrier screening does not replace other pregnancy genetic screening such as NIPT. Reproductive carrier screening tests for severe childhood onset conditions, so recessive and X-linked conditions, and that it is a screening test and therefore there are limitations and cannot guarantee that a child will not be born with a genetic condition, but does lower that chance. I've just got a QR code or a link here to a very quick Mackenzie's Mission survey. Would really appreciate if people are able to complete that. Just asking about your views on reproductive carrier screening. So I'll just leave that up for 2 more seconds. And then I think that's us
for
done.
Questions. Yeah. Yes.
Thank you very much for the discussion and introducing the group, the participants to Mackenzie's Mission. Right now, what should supervisors support their registrars in prenatal testing, prenatal genetic testing? What advice should they give? Clearly, if they're a practice who's involved in Mackenzie's Mission, that's one level. But what advice would you give to the broader group of supervisors in terms of supporting the registrars to offer appropriate prenatal testing?
So I think, first of all, addressing it from the general practice perspective, there's so much to go through particularly in that early pregnancy discussion. So if it needs to be split over, several appointments, depending on the way that your appointments are structured, then that, it's a discussion that is really necessary to have as per the RANZCOG and the RACGP guidelines, ideally pre-pregnancy, but we all know that people often come in and they're pregnant, and that's when you first get the opportunity to have that talk. So if somebody had not any idea how to go about the discussion, I think Beware the Rare is a really good resource to start with, and do that CPD module for an hour and get the CPD points if you need them. And it really does address a lot of the key points, as does the New South Wales Centre for Genetic Education, and as do a lot of the private companies. Mackenzie's Mission, if you are a recruiter, does do a lot of that education with the patients for you. And particularly, I'm a recruiter for Mackenzie's Mission, and I know that we still discuss it, what it is, what it's about, what carrier screening is, but then a lot of the considerations that are ultimately up to that couple and that individual to decide if they want to go ahead really gives them an opportunity to reflect on that as well.
A question, I believe prepare costs $385 for one and maybe $750 for two, but expanded carrier screening is $880 for both parents. I'm just reading from a question here. So why not choose the broader test when cost is so similar, but you can get 300 conditions rather than 3? And I guess that is a really important question, I think. How do we broach that topic around the fact that we can order a prepare test and there's 3 conditions, but in fact we could screen for 300, but they're less common and maybe less severe or significant?
Yeah.
How do we teach registrars to, those very sort of tricky nuances of risk assessment and that sort of thing?
The couples like that all the time, where we're trying to sort of gauge where they're at in terms of, how much information is too much information. So some people will find, screening for hundreds and hundreds of conditions is too overwhelming, and they just want to focus on, these are the more common things, that's what we're at higher risk of, we'll just go for the 3. Whereas some people want absolutely everything. They don't care, if it's 1,000 conditions, they want it because they want that information. So it's about, I think, exploring as much as you can in such a limited time frame, exploring with the patients about what their level of, their perception of risk is, and I guess what they'd be comfortable knowing. So I think to sort of say, this is what's available. There's lots of different commercial companies available. Maybe the patients can go home and think about it, have a discussion, and then come back and make a decision from there. So I think it's important to know that people don't have to make a decision straight away. They may need to go home and do some Googling, particularly on our Mackenzie's Mission website as well. We've actually got a list of other commercial companies that are available too. So that's, if you need a list of all the companies that are available, they're on Mackenzie's.
Yeah. And on that, Kirsten, you just to the extension of that is, what should supervisors apply in their own practice and teach their registrars around individual or couples-based screening? Again, is that a discussion and try to meet the couple's wishes in that regard?
So that's where I was going to go then. So obviously the more conditions you screen for, the more chance, knowing that we all carry, one or two or up to five sort of carrier conditions, the more you test for, the more likely you are to find something abnormal. And that may be a rare condition, so getting into some of the complexities, but it sort of depends on the carrier frequency in the population. But there's a chance then that you'll have to do the other partner, and then that will take time and also often costs almost as much. So for the people that elect to screen individually for the full panel of conditions, there's a chance that they may be identified as a carrier for something, if that makes sense.
Yeah.
Now, can I ask you, Caitlin, to flip back through the slides to the MCQs? There's been one request to give the answers, which I think just would be worth doing. And while you're doing that, Kirsten, just a very specific question around a small country town in New South Wales, Temora, where there's a very high prevalence of CF, I gather, due to the population there. And how, for that particular location, but maybe in other centres where the Mackenzie's mission is addressing particular pockets of high rates of genetic conditions.
So sorry, how would they?
Is there any kind of notion of trying to recruit more couples through in areas where there's known high rates of genetic conditions?
I guess that's not our primary aim, because we're trying to get a broad representation of the population as it stands. Our particular focus on southwest and Western Sydney is to get different ethnicities involved. But certainly, if there's regional people that want to be involved, I think that's important that we have representation from regional areas of Australia. So I'm very happy to hear from that particular person, and we can look into whether they can be involved.
Yeah, so the questions were a couple who receive a low chance screening result still have a chance of having a baby with a genetic condition, and almost everybody answered that true.
That's true.
And the answer is true, because with the limitations of testing, you can have false negatives depending on whether they choose, particularly if they choose just the three test screening, then they haven't screened for all those others. But even with the limitations of testing, not every variant's known, not every genetic condition has been defined at this point in time. A couple who receive a high chance screening result will be unable to have children together in the future. So no, they're really the ones that have the options, and they're high chance in Mackenzie's mission as a couple. So you don't know your individual you'll know the condition that you're at high risk for, but if you screen low risk, you may still be a carrier for something. It's just as a couple, you haven't been identified for Mackenzie's mission. So a couple who receive a high chance screening result do have options to have children, and that may be, as Kirsten said, you could do IVF with PGD or PGS or PGT. You could do invasive testing in pregnancy, either through CVS or amnio, or you could elect to take the chance, and for recessive conditions, that's 1 in 4. Yeah, so the last one, so no, we still need to do the non-invasive prenatal screening or combined first trimester screen, or have that discussion.
I would really like to thank you both for what was a very comprehensive discussion on what is really a pretty difficult and challenging topic, I've got to say. I can imagine many of the supervisors are thinking, this is hard. I don't know that I feel comfortable with this, let alone practice, and how do I teach my registrars? And I guess you've addressed that well, Caitlin, around needing to upskill. I mean, this is an emerging area. We will be engaging with this so much more in the next 5 and 10 years, and certainly our registrars, this will be bread and butter to the way they practice. And so I guess it is incumbent on us to access the right resources. I'd certainly plug the RACGP resource. I'd plug the Beware the Rare site you've talked about, the Centre for Genetics Education in New South Wales, and our friendly genetic counsellor like yourself, Kirsten, I think, can be really incredibly helpful. We have a bit of a flurry of webinars, so there you go. The 29th, so in 9 days. teaching registrars around treating patients with a history of childhood trauma with Louise Stone and May Sue. Andy Morgan, who's an experienced medical educator, observing a registrar on the 5th of November, and the third session on chronic disease management and health assessments on the 24th of November. So yes, as usual, GPSA is funded by the Australian Government under the AGPT, and very grateful for their ongoing funding, and very grateful for your role as supervisors, and certainly your interest and keenness in attending upskilling events like this tonight. So I think that's our last slide, but I would like very much to say thank you so much, Caitlin, Kirsten, for your contributions tonight. If you are interested in Mackenzie's mission, I know they're recruiting, they're keen to have GPs who are engaged. I think teaching practices with registrars on board would be ideal. But if you are not in the catchment zone, or that's not a strong area of interest, then I guess the big message from this to me is that reproductive carrier screening is part of best practice, part of routine practice for prenatal and early pregnancy couple management, and we really need to be across that and be across it in terms of teaching our registrars. So thank you so very much all, and we look forward to catching up at another webinar soon. Thanks for coming along, and we'll see you soon. All the very best.
Thanks for having us.
Thanks so much for having us.
Thanks, Zen.
Bye.
Bye.